arthritis. The future is now. This session will be recorded and will be available on the online platform after the Congress. There will be a Q&A after the presentation. Can also be entered via the app. My name is Connie van der Laken. I'm a rheumatologist based in Amsterdam, the Netherlands, and my co-chair is Sarah Orndorff, based in Potsdam, Germany. In this session, you will learn about new advances in imaging, including new technologies and AI integration. And it's now my great pleasure to introduce the speaker of this session, Professor Anna Maria Inoco from Turin, Italy. She is a highly respected expert and internationally recognized rheumatologist and researcher and past president of the EULAR. She has contributed significantly to various fields in rheumatology, including in imaging of arthritis, particularly on ultrasound. So we look forward very much to hearing her overview of the newest developments in imaging in rheumatoid arthritis. So please, the floor is yours.
Thank you. Thank you so much for this kind invitation to the scientific chairs and committee. And it is my pleasure to update in this presentation and give more recent news about the use of imaging in rheumatoid arthritis, particularly with a focus on new technologies. Those are my disclosures. Those are the learning objectives that have already been mentioned a few minutes ago. I will focus particularly on the advances in technology and also artificial intelligence integration. We know that inflammation and structural lesions are the main components, the main factors contributing to the development of rheumatoid arthritis. And we know already that very well that inflammation and damage are well beyond the joint. They can be found within the joints in the musculoskeletal system, with synovitis and damage at different joint sites, but also at the musculoskeletal periarticular structures with tenosynovitis, bursitis, tendon damage. But we know very well that we have also an organ involvement with inflammation and damage. Where are we now in this context in 2026? We know many things about rheumatoid arthritis. We know that it is a chronic heterogeneous disease. We know how to manage the disease based on the treat-to-target standards, but there are still some unmet needs, particularly in the detection of subclinical inflammation in patients who are in very early phases of the disease, or also the difficulties in predicting flares. In this context, imaging can have an important role. For the assessment of musculoskeletal manifestations, we have already a number of conventional imaging modalities that are available in the majority of our clinics. They are represented by X-ray, of course, by MR, by ultrasound. All of them with different perspectives and sensitivity are able to show damage, particularly in the case of X-ray, but also inflammation within the joints and at periarticular level. But we know that X-ray, CT scan, PET, MR are also important components of the imaging evaluation for organ system involvement in rheumatoid arthritis. That is a very important aspect. The comorbidity represents a crucial point to assess in our patients with rheumatoid arthritis. But we have also innovative imaging techniques nowadays available, and there is a rapid advance in technologies with a number of new tools and new modalities that are available in different contexts. For conventional imaging, we know that X-ray is able to show the damage, the bony damage, the erosions, the subluxations, deformities, and so on. But however, it is a tool that is not sensitive for very early findings. It shows late damage. MR has an incredible advantage, the capability to show bone marrow edema, and on top of this, to show also synovitis, tenosynovitis, and other inflammatory aspects, therefore being the gold standard for assessing inflammation at different joint sites and periarticular level. However, we know also that there is a limited availability and access in the equipments used in the clinical practice. What about ultrasound? Well, ultrasound has a very important advantage of being very sensitive for showing inflammation, showing also structural lesions. It is very friendly, well accepted by patients, and it has the advantage of being used as a bedside procedure. So we can show the patient the abnormalities on the screen, on the monitor, and the patient can also be educated on the relevance of the adherence to treatment. For example, when we explain which are the main pathology and the main lesions that can happen or are already established at their joint level. However, standardization is crucial for this tool. So why imaging matters? Where are we now? Essentially, imaging, especially with the new technologies that I will show you in a minute, is able to be the game changer in some cases in rheumatoid arthritis because it shows what clinical exam cannot. Indeed, clinical scores sometimes can miss subclinical disease. It shows subclinical synovitis in patients with early disease or undifferentiated pathology, or it shows also residual inflammation in some patients who are already in remission as based on the clinical definitions for remission. The recommendations of EULAR for the use of imaging in rheumatoid arthritis represent the standard for us. And they state that when there is a diagnostic doubt, ultrasound or MR or imaging in general can be used to improve the certainty of the diagnosis as they are able to show inflammation that is difficult to be detected by clinical examination. The presence of inflammation also predicts the development and the progression to rheumatoid arthritis in patients who have undifferentiated disease, and also it is possible to show very early in the disease course erosions or structural lesions that predict the progression to rheumatoid arthritis. Therefore, imaging can be used in the concept of the window of opportunity. And in this nice paper that we published a few years ago, we highlighted the relevance of imaging, particularly, for example, a high-resolution CT scan for showing structural bone damage in healthy individuals who are ACPA positive, or to show the signs of synovitis, tenosynovitis, or inflammation at the musculoskeletal level in patients who have only clinically suspected arthralgia without any clinical manifestations of arthritis. Or we can use imaging to show again already inflammation and structural lesions in patients with unclassified arthritis or oligoarticular arthritis, and we can also evaluate the different stages of the development of rheumatoid arthritis with demonstrating inflammation and damage. So imaging, also in the preclinical phases of the disease, can have a role as a predictor for the development of rheumatoid arthritis by showing very early the presence of inflammatory abnormalities, and by detecting inflammation, it can give an added value to clinical examination. And the early visualization of subclinical sign of inflammation by imaging can also support in the identification of people who are at risk of developing rheumatoid arthritis. And this is a nice study that was published a few years ago, highlighting the high accuracy of the combined assessment of patients with clinical history and examination, imaging finding, and laboratory tests for the identification of patients in the early stages of the disease. Indeed, we know by the recommendations that imaging is superior to clinical examination for the detection of joint inflammation. Very early in the disease course, it is possible to show these inflammatory findings. And also in patients who are already in remission, it is possible to detect subclinical inflammation and some signs of structural lesions. Indeed, the recommendations for the management of early arthritis, published a few years ago by EULAR, show that clinical examination is, of course, the method of choice for detecting arthritis, but ultrasound or imaging can help, can support in the identification of the difficult to diagnose cases. It is possible also to predict the progression of damage and response to the treatment when inflammation is present, and it is possible to monitor disease activity and disease progression. But of course, the added value of imaging is also the assessment of the cervical spine. The involvement of the cervical spine, particularly the atlantoaxial subluxation, is difficult to be evaluated by physical examination, and really imaging can have an important role in this context. But also in difficult to treat rheumatoid arthritis, imaging can help to identify those patients who have, for example, comorbidities or other diagnoses overlapping difficult to treat array, for example, fibromyalgia or osteoarthritis, that can contribute to the persistence of symptoms and then can help in the correct identification of those who are clearly or really in difficult to treat because of the persistence of inflammation. So imaging with ultrasound go beyond the bedside assessment, analyzing synovitis, sinusoinovitis, predicting flare and damage, guiding some treat-to-target decisions and helping in this context, and also identifying those who are at risk of progression or at risk of flare. But MR is really a relevant and crucial imaging modality, as it sees what ultrasound cannot see, essentially bone marrow edema. As you can note here, it can show and differentiate the severity of inflammation, for example, in rheumatoid factor positive patients compared to those who are negative for rheumatoid factor and have less inflammatory abnormalities at the level of the joints. It can also show early erosive damage, predict the damage progression, and stratifies patients who are at risk. But if this is the state of the art, we know a lot about the future developments, because the incredible advances in technologies with technological production of sophisticated tools can highlight minimal details of the pathology, subtle lesions that can be present in the patients with rheumatoid arthritis. And in this context, if we are aware of already established advanced imaging, we also are aware of the advances in technological developments with cutting-edge technology, which shows minimal findings and also lesions in the different phases of the disease. Starting with ultrasound, what you see here is the assessment of the patellar tendon in a patient with rheumatoid arthritis. This is a very accurate assessment of the tendon fibers, and you see here we can go from microscopic to macroscopic. You see the small details of the parallel fibers that are normal, but we see the lesions at this level. That is a small bursitis, infrapatellar bursitis, that is clearly detected. But with high-resolution ultrasound, we can also show the regularity of the hyaline cartilage. This is the cartilage at the level of the metacarpal head of a healthy individual. And you see also the lesions that can appear in rheumatoid arthritis. These are different cases with sinusoinovitis demonstrated by B-mode or with Doppler ultrasound. With the use of high-resolution ultrasound, we can demonstrate the different findings and also differentiate them in different joint sites. Or we can use ultrasound or imaging in general for planning the preoperative plan. And the surgeons are used to assessing ultrasound before starting the surgery in order to know better how to develop the surgery during their interventions. But cutting-edge technology is also the use of ultra-high-frequency ultrasound. Those frequencies range between 50 and 70 megahertz, and they allow for the assessment of minimal abnormalities in small areas and structures, such as the pulleys, the tendon insertion, the aponeurosis, the distal ramification on peripheral nerves, and they are also able to show minimal signs of synovitis very early in the disease course. You see some example of 70 megahertz probes frequencies applied for analyzing minimal subtle changes in the hyaline cartilage or in the tendons and in the tendon sheets. Or they can be able to evaluate the pulleys, for example, that are with a submillimetrical assessment of small lesions at this level. But the current imaging is also based on the use of three-dimensional ultrasound. This is a volumetric probe that can be positioned over the area of interest, the area of study, and you see what the images that are detected and that can show the presence of tendon damage, bone erosions, synovitis in a very accurate manner, analyzing this information and this data with a volumetric assessment. By using this volumetric probe, we can reduce the issue related to the expertise of the operator, of the ultrasonographer in the acquisition phase, because the information are taken by this volumetric probe that is positioned in the area of study. And these applications are very promising, and they are always on site included in our machines. And you see this here an example of a PIP joint of a patient with rheumatoid arthritis. X-ray only shows a minimal irregularities of the bony cortex in the joint, but 3D ultrasound demonstrates a large erosions and is also able to show the very severe Doppler that is showing the presence of a very active inflammation related to hypervascularization. But if we are aware that Doppler is very sensitive, particularly with our new machines, we know by new technology that we can use super macrovascular imaging. For example, there is a very sensitive tool for the assessment of the very slow flow that are those that are present in the joints of our patients with rheumatoid arthritis when we have hypervascularization. This is an interesting study that has been recently published by our group with João Dias as the first author. And this study demonstrated that in rheumatoid arthritis patients, the Doppler was sensitive, but the higher sensitivity for the detection of the pathological flow was obtained by this super macrovascular imaging. And this is another example with power Doppler and the SMI that shows this pathological vascularization in a very detailed manner and with high sensitivity. And so far, the studies that have been published on the SMI show that they were mostly focused on rheumatoid arthritis and also particularly on the assessment of joint vascularity. Another tool that is already available in our machines, in our clinics, is represented by sonoelastography. That is important because it is able to evaluate the strain, the elasticity of different tissues, and to differentiate, for example, between the presence of local edema in the soft tissue from hypervascularization related to active inflammation. And this is an important information that we need to have when assessing our patient. But cutting-edge technology is also based on the use of fusion imaging and integrated imaging. Based on this integrated imaging of fuse assessment, we can obtain, for example, you see here the ultrasound evaluation on the top of the image showing Doppler signal and synovitis, and in the lower part, this is a CT scan that is overlapped over the imaging of ultrasound, showing erosions and bony damage. On the right side, this is a large osteophyte in a patient with rheumatoid arthritis that is associated with rheumatoid arthritis related to the progressive damage in this joint, and you see the complete set of information coming from ultrasound and MR. And these are the images of this patient with overlapping and fused imaging that shows information coming from both tools with a very detailed and panoramic analysis. So essentially, what do? We take the images from the basic tool that is MR or CT scan, for example. We upload this in the ultrasound machine, and this is the virtual navigator which in real time overlaps the images from the different modalities, giving a very panoramic view of the area of interest and taking the advantage of showing abnormalities coming from different modalities. Another important integration is based on the parallel use of different tools. This is, for example, MR, ultrasound, and fluorescence optical imaging in rheumatoid arthritis patients, showing the presence of synovitis in the fingers or joints of these patients. Optical imaging is a tool that is based on the assessment of and quantification of inflammation in the superficial joints by evaluating the blood-specific absorption of light transmitted through a specific tissue, in this case, the tissue which is inflamed, the joint areas. So this is following intravenous injection of a fluorophore, and is based on the concept that inflammation influences the light traveling through the tissue, and therefore it can distinguish between healthy and inflamed joints. This is an interesting study that was recently published by a German group that coordinated by Xenophon Baraliakos, who this group evaluated and investigated the performances of optical spectral transmission in evaluating the inflammation at the joint level, and compared this assessment with MR in patients with inflammatory disease. The patients with inflammatory arthritis were compared to healthy individuals, and essentially optical spectral transmission showed excellent performances when compared to MR, correlating with the Ramris score, that is the score for assessing synovitis by MR, but also correlated with the clinical parameters, and was able to differentiate between inflammatory arthritis and healthy individuals. And those are the images from this interesting study taken by MR and optical spectral transmission, and you see the inflammation that was located in the small hand joints. What about MR? Well, MR has demonstrated incredible advances in the last years, and particularly the use of dynamic contrast enhanced MR has even highlighted the sensitivity for MR, for conventional MR, for assessing bone marrow edema and synovitis, and also for assessing erosions and structural lesions very early. You see, for example, the assessment of the joints by using dynamic contrast enhanced MR, and in rheumatoid arthritis patients, the synovitis and the inflammation was mostly present within the joints, while in PSA patients, they were present at the periarticular level. This is another interesting application of MR that is based on the use of fast protocols with 20 minutes acquisition time protocol that is extremely fast by using a 3 Tesla MR assessing the whole body. It is possible to acquire an incredible number of information on inflammation and structural lesions, as well as on the organ involvement, as I will show later on in a few minutes, in patients with rheumatoid arthritis. These fast protocols are clinically feasible. They have a whole number of complete number of inflammation, an extended number of information on different joint sites, and these are this tool is able to differentiate between healthy subjects, rheumatoid arthritis patients, and other kind of arthritis by exactly analyzing the sites of the different abnormalities. And this is the protocol as it is performed with this fast acquisition, 20 minutes, to having a whole body assessment of the joints, the musculoskeletal structures, and the organs. But maybe an underestimated structure when we think to rheumatoid arthritis patients is the cartilage. At the level of the cartilage, we have a number of abnormalities and degeneration and lesions that can be carefully evaluated in details by using quantitative cartilage imaging methods based on MR evaluations. They are, for example, T2 mapping, T1 row mapping, or DGREM GEMRICH, that is based on the use of a contrast media, and they are able to evaluate cartilage breakdowns, decreased organization of the matrix, loss of proteoglycans and glycosaminoglycans, increased water content, and they are also able to detect changes very early in the disease course. This is a study based on T2 mapping for the assessment of cartilage damage in rheumatoid arthritis. The hand joints were evaluated in these patients, and this study demonstrated that the cartilage damage can be localized and quantified in details in the different joints. And it correlated with the rheumatoid factor or ACPA positivity, for example, that were considered to be the crucial factors for influencing the progression of cartilage damage. This is another interesting study that was based on the use of quantitative evaluation of the volume of tenosynovitis by using MR. This was a study that was, again, based on a FAST protocol, the one that I mentioned a few minutes ago. And in 223 ACPA-positive individuals without clinical manifestations of arthritis, this quantification of the volume of the tenosynovitis and synovitis gave important details on the progression of the disease because it was able to provide to demonstrate that this tool provides independent predicted value beyond the binary evaluation of presence or absence of tenosynovitis and synovitis. And these measurements also provide very interesting information in terms of the individualization of the risk factors. What about the CT? We know that the bone assessment is crucial for us for evaluating the progression of damage at the different joint sites in patients with rheumatoid arthritis by the use of high-resolution CT scan that is already a standard in our departments. We can evaluate the trabecular and cortical bone, thinning of the bone, early erosions, and we can assess also the presence of erosions within the bone, that particularly in the hand joints. This is a high-resolution quantitative assessment by CT scan that shows, compared to X-ray that looked normal, the presence of erosions within the bones at the level of the metacarpal heads. But advanced imaging is also based on the use of DECT. That is a very relevant modality that is able to replace sometimes magnetic resonance when this is not available or when it is contraindicated. By using DECT, we can evaluate bone marrow edema, synovitis, erosions, but also in particular crystal deposits, which can be important for differential diagnosis. So we can perform a synovitis mapping, an analysis of structural lesions, but also we can evaluate, and this is very important, bone marrow edema. This is a recently published study for the evaluation of for analyzing, by using contrast-enhanced DECT, that was analyzing different patients with early arthritis, and it was able to perform a differential diagnosis by, for example, being able to detect the presence of crystals or the presence of osteoarthritic changes that could highlight the importance of this tool. For example, in 50% of those cases, the initial clinical suspected diagnosis was modified. Or DECT can also be used for bone marrow edema evaluation. This is a case, this is a study that was recently published evaluating the bone marrow edema at the level of the wrist joints, and this was demonstrated excellent diagnostic performances also when compared to magnetic resonance that we know is the gold standard for assessing bone marrow edema. What about nuclear imaging? Well, PET depicts the pathophysiology of tissue at the molecular level, enables the delineation of the PET signal, and the recent developments of specific tracers for rheumatoid arthritis imaging show the relevance of these tools also for showing the presence of inflammation. This is arthritis in the knee, or this is a whole body PET scan by using FDG for assessing joint involvement at different levels, but also organ involvement. This is an overview on the use of nuclear imaging modalities that are extremely sensitive for assessing inflammation at different joint sites, and they provide a rapid whole body assessment of different inflammatory findings. However, there is a radiation burden that should be considered. These are some examples of MR, ultrasound, and scintigraphy showing synovitis in these hand joints of a rheumatoid arthritis patient. But in this case, in the lower part of this slide, you can also see the presence of different abnormalities in a rheumatoid arthritis patient with MTP joint involvement. And on the left, you see enthesitis of the Achilles tendon and the plantar fascia. This was a patient with psoriatic arthritis. But what about organ involvement? We know how important it is for us to evaluate comorbidities and the involvement of different organs, both in rheumatoid arthritis, both in terms of inflammation and structural damage. X-ray, PET, MR, ultrasound are important components in the assessment of these comorbidities, but innovation with the new technologies show also additional abnormalities in small details. This is something that we all know, the use of high-resolution CT scan for the evaluation of the lung in rheumatoid arthritis. This is a comorbidity present in up to 40% of patients with RA. And CT scan can show bronchiectasis, honeycombing, shadowing at different levels in the lung of patients with rheumatoid arthritis. But by using whole body MR, also with the use of fast protocols that I showed a few minutes ago, we can have a complete overview not only of the joints, as I mentioned already, but also of the different organ involvement. And you see, with these fast protocols, with 20 minutes, we can have really a complete assessment of the whole body, also in terms of comorbidities. Another interesting tool is the use of radiofrequency quantitative evaluation of the intima media thickness. That is an important component when we assess patients with cardiovascular risk. This is the automatic measurement of the intima media thickness in a healthy individual. You see the measurement, and this is what happens in a patient with rheumatoid arthritis with the thickening of the intima media thickness. And this can help in recognizing those patients who are at high risk for cardiovascular disease, and this assessment is done automatically in a very reliable manner. But we can also use fluoroscopy, for example, that is an X-ray modality to produce real-time moving images of the body. And this can be helpful for diagnosis comorbidities or conditions associated with rheumatoid arthritis. This is a case of a patient who had esophagus involvement. But the future is now, or is just around the corner. There is such a rapid evolution of technology that we can use different modalities at the same time to evaluate the joint, the periarticular musculoskeletal structures, to evaluate other organs, and altogether this assessment can be done from the same control room by the radiologists and the rheumatologists that work together and come and discuss the different cases based on the different perspectives of the disease. Yeah, so all these big data can be clearly analyzed and evaluated, and even innovative imaging modalities can be included in this assessment. And this is the role of artificial intelligence. So by artificial intelligence tools, we can evaluate a huge amount of data, and we can assess different structures at the same time with limited or no need for the human brain intervention. This can be done at the level of the organ or for assessing joint structures at the axial level or at peripheral level, and particularly this analysis gives detailed information, particularly when we want to evaluate a huge amount of data coming, for example, for registries or for multi-center clinical trials. Artificial intelligence, when the system is well trained, gives an automatic detection of the finding, a standardized assessment, very fast assessment of the different lesions with an automatic reading and reduced inter-observer reliability, so that this system can be used for detecting the lesions, for classifying them, but also for scoring and predict the evolution of the disease. When we evaluate X-ray in the clinical practice, of course, we don't need artificial intelligence for one or few joint images, but when we are evaluating many images, many assessments in clinical trials, in registries, or when, for example, we have radiologists who are not expert in musculoskeletal assessment or X-ray, then these artificial intelligence tools can be helpful. The same is for example, for ultrasound, which has a long learning curve, and we can submit to the artificial intelligence assessment both the images already taken by the expert ultrasonographer, or we can also use a robot for also scanning the different joints. And the same is for MR, that is when it is possible to assess different areas and multiple information with a very high quality evaluation. This is a study that was based on the Swiss registry of rheumatoid arthritis, and the hand joints were evaluated for assessing the structural lesions at the level of the hands, and these neural networks that assessed the joint damage was very accurate and very reliable when compared to the human assessment. This is another study that was based on the assessment, the evaluation of the atlantoaxial joint for assessing subluxation in rheumatoid arthritis. And again, the artificial intelligence evaluation, when the system was trained with a huge number of images, was able to detect these abnormalities and those lesions with high sensitivity and specificity. But for ultrasound, we mentioned there are different challenges, both in the scanning procedures, in interpretation and recognition of finding, and we can use an automatic acquisition, but also particularly we can acquire the images and send them to the assessment of the artificial intelligence tool. And in this case, this was a study, again, evaluating the synovitis in the wrist joint by ultrasound, and the system, the artificial intelligence system, was highly accurate, sensitive, and specific for assessing the severity and also the presence of Doppler signal. And the evolution of this system used based on multi-assessment by different neural networks even highly improved the accuracy and the sensitivity for evaluating synovitis in the hand joints in this study. Or another possibility is to use artificial intelligence for delineating the region of interest that is considered to be the region where synovitis is present, and the system automatically scores and detects and scores synovitis in rheumatoid arthritis. But artificial intelligence can also be applied to MR images. This is a study that is focusing on the assessment of the hand wrist joint in patients with seronegative rheumatoid arthritis, seropositive rheumatoid arthritis, with psoriatic arthritis, and in patients with only skin lesions, psoriasis without any manifestation of arthritis. And the system was able to differentiate between different diseases, showing synovitis mostly in the joints of rheumatoid arthritis patients, while in PSA, but also in patients with only psoriasis, the periarticular involvement was prevalent. This AI can also be used for assessing and detecting and scoring the severity of bone marrow edema in the wrist of patients with rheumatoid arthritis, and this assessment was extremely helpful and highly sensitive, with the same sensitivity that was demonstrated by the human eye evaluation. And finally, the high-resolution CT scan. This is another application of artificial intelligence that evaluated the hand-bone shapes from high-resolution CT in patients with different diseases. And these neural networks, which were trained for this evaluation, were able to discriminate between RA and PSA and healthy individual based on the shape of the metacarpal head. So, concluding, artificial intelligence has demonstrated to enhance the accuracy in the diagnosis and differential diagnosis of different pathologies, including rheumatoid arthritis, and imaging data sets are crucial in this evaluation. By evaluating a huge amount of data, analyzing big data, artificial intelligence can perform well, and when the system is well trained, you can rapidly assess different joint size and evaluate different lesions. But innovation is also in the space, and you see an astronaut that is flying in the shuttle by using the same machine that we use in the clinical practice and evaluating the joints of himself and the other astronauts. Maybe we can have important information in the future on the optimization of treatment with rheumatoid arthritis, because we should never forget that imaging for us is not only an exercise, is a number of information that we can acquire and we can obtain for optimizing the patient treatment and for optimizing the management of patients with rheumatoid arthritis. That is our final aim. So in conclusion, artificial intelligence, this is very promising. It is able to show different lesions. It performs very well when the system is well trained, of course. And it is really giving a support to the clinicians in different assessments. Of course, the feasibility and the application in clinical practice and the implementation is a slow process that we hope will be active in the next future. And in conclusion, for my presentation today, I can say that imaging is central, and many validated advanced technologies are already available. But innovative technology is now, but is also around the corner and represents already the future, with new evidence and cutting-edge technology that maybe shows that the future is already here. Of course, the big challenge is implementation. And thank you so much for your attention.
Thank you very much, Anna Maria, for this wonderful talk. Very innovative, very colorful talk. Thank you so much. Are there any questions from the audience? I think we still have some minutes left.
Hello.
Elfita.
Great talk. Thank you very much. I'm Elfita Sabedin. I'd like to ask, in the future, this is about the SMI technology. So in the future, do you think we can understand the clinical importance of the extra vasculature that you see with this technology compared to Doppler? And do you predict that we might be moving to SMI from Doppler?
Well, it's a technique that is extremely sensitive, and all our machines nowadays are already equipped with this SMI or other similar technologies. Doppler is already very sensitive, but for the very small flow in the small hand joints, I think it has been demonstrated that it shows with higher sensitivity the presence of pathological vascularization. So maybe this was, so far was done mostly in the small hand joints and wrist joints, but maybe we have to see if this is also, as a future application, valid for or applicable for the detection of flow in the deep joints, for example, the knee or the hip, where conventional Doppler modalities are have low sensitivity. We have something that we have to consider for future developments.
There is another question online, Anna Maria. Thank you very much. The newer techniques using ultrasound MRI will require significant investment and training. We already know this discussion, of course. There are concerns about identifying features which may be of limited clinical relevance. What do you think about these issues? Are you able to comment on the cost of utility of these new techniques?
Well, but these techniques are already, in most cases, they are already included. They are only softwares that are already included in our machines. So for ultrasound, for example, that we use in many centers in the clinical practice, SMI or elastography or 3D ultrasound, they are already there. It's only a software with limited cost if it is not available. For the other technologies, those are available in the radiology unit. And this is why I showed to you the cabin room with radiologists and rheumatologists together. It's not something that we can do on our own, but it is a collaboration with the colleagues in the radiology departments that together discuss and highlight the different components of this pathology. And it's not a very relevant risk because the radiologists have really, the modern radiology departments don't never do only X-ray or basic MR. They all have rapid advances in technologies, and this is based on their on the normal equipment of their departments.
Thank you very much. I think we are already at the end, unfortunately. Thank you so much for your wonderful talk again and for this sharing.
Thank you, and thank you for coming on the Saturday. Enjoy the rest of the Congress. Thank you.
So, good morning, ladies and gentlemen. It's my honor to welcome you here on the very last plenary session, which is given on rheumatoid arthritis with the abbreviation of HOT, how to treat, and we will learn, I think, a lot on the pathogenesis of RA and the translation to the novel pipelines of rheumatoid arthritis. My name is Ladislav Šenold. I'm a rheumatologist based in Prague, at the Institute of Rheumatology and Charles University in Prague, and it's my honor to co-chair this session with Claire.
So, hello everyone, my name is Claire Mediato-Dayan. I'm a rheumatologist in south of France, Montpellier, and I'm very happy to be here. Thank you for your courage that will be rewarded by the nice presentation of Elena Nikiforou. She's a clinician academic rheumatologist in King College of London, and she's very interested in difficult to treat RA, multimorbidities, and the floor is yours, Elena.
Thank you very much, Claire. Thank you, Ladislav. Thank you to the EULAR organizing committee for inviting me to deliver this talk. It is a great honor to be standing here in front of you all and about to deliver in my own way one of the most remarkable success stories in modern rheumatology, the story of RA. a true story of extraordinary paradigm shifts and a future full of promise. But let's take a step back and think about this RA paradigm shift and what we really mean and why it was needed. And in medicine, ultimately, every paradigm shift begins with a patient story. So let's think of this 32-year-old female patient who presents with a 6-week history of polyarticular pain and swelling. It's found to be rheumatoid factor positive, subsequently also ACPA positive, and is given a diagnosis of early seropositive rheumatoid arthritis. 2 to 3 decades back, she probably wouldn't be diagnosed this early. She would be using non-steroidal anti-inflammatory drugs, maybe a bit of steroid. We would be using step-up combination synthetic DMARD in a slow manner probably, whatever would be available at the time. We would be monitoring rather infrequently, and we would be accepting a level of ongoing disease activity. I am aware that some of you have witnessed these patients firsthand. In my case, I have come across these patients later on in their journey with RA in follow-up clinics. I've studied them in historical cohorts as part of my research. What would happen to this patient now is that they would likely be promptly starting methotrexate and a bit of steroid. We would be treating to targets of remission. We would be tightly monitoring and having a low threshold to escalate treatment to advanced therapies. The difference between then and now in terms of outcomes, well, back then, would be allowing persisting inflammation, joint damage, functional decline, poor quality of life, whereas now we will be getting on top of the disease, we will be preventing damage and preserving function and quality of life. So the paradigm shift essentially refers to that transformation from accepting ongoing inflammation and disability to a more treat-to-target approach to care, treating early to target and aiming for sustained effects. So essentially a shift from a very reactive to a more proactive approach to care. Why was it needed? Well, because the old way accepted ongoing inflammation and structural damage, disability, debilitating patient symptoms, whereas we now have the tools, we have the drugs, and we know how to treat these patients in a way that prevents these adverse outcomes. We also have greater insights in disease. We understand that RA is a heterogeneous disease. So we can and we have to do better for our patients, and that's why this paradigm shift was needed. So I will put it up front, right here. The message around which this talk will revolve is this one. We have fundamentally changed the natural history of RA. The question is no longer whether this is possible, but how we ensure that every person living with a disease truly benefits. So over the next 30 minutes or so, I will take you through some disease insights. We'll talk a little bit about the evidence that has informed current practice. We'll touch on the treat-to-target logic. We'll talk about advanced therapy choices and what the current guidelines tell us. And then we will focus a bit more on difficult-to-treat disease and insights around this, which is a key objective for this session. We'll think about precision and personalized medicine before we finish off with a few reflections into what the future might bring. There have been huge advances in the past few decades. Before the 1980s, the focus was on broad disease classification, understanding basic pain and inflammation mechanisms, basic drug development. In the 2000s, we moved to the targeted therapies, the biologic revolution, TNF inhibitor discoveries, biomarkers, cleverly designed clinical trials that informed the way we treat our patients today. And presently, we talk about personalization, precision medicine, novel targets, preventing disease before it even begins, early intervention before joint damage. And alongside, we were seeing increasingly more motivated patients, I believe, patients who want to take a more active role in their care, who place emphasis on self-management interventions like the way that we eat, the way we drink, the way we sleep, physical activity. And alongside, and part of the parcel we've heard it earlier from Anna Maria, it's digital health and artificial intelligence, which are here to stay. So this big transformation, this major shift in treatment paradigm, to my opinion, comes from a fundamental change in treatment philosophy. For years, we accepted ongoing inflammation. We were reactive in the way we were treating our patients. We waited for visible evidence of progression before escalating treatment. But with landmark trials like the TICORA, the BEST trial, we learned of the importance of early and intensive intervention and how this influences outcomes also further down the line. We learned of the importance of treating early and intensively, also to prevent radiographic progression. And these landmark trials were part of that first revolution, but they were not the final destination. We also learned from this and many other trials of the importance not just of achieving early remission, but also sustaining it in the long term. Here we see the BEST trial results, 7 years from the start, and we see that early effects are sustained in the long term in terms of physical function, disease activity control, prevention of radiographic progression. So it's important, I repeat it, not just to achieve early remission, but also to maintain it in the long term. I talked about radiographic progression. And orthopedic surgery in rheumatoid arthritis has been studied as a surrogate marker of end-stage joint destruction in RA. And I believe that the declining need for orthopedic surgery in RA is one of the real-life markers that the disease itself and its long-term trajectory has fundamentally changed. Here we looked at 2 historical early RA inception cohorts in the UK, the ERAS and IRAN cohorts. We studied them across 4 time periods, spanning a period of 26 years between them. And the earliest periods are represented by the blue lines, middle periods, red and green line, and the earliest time period is represented by the IRAN cohort, the yellow line. We looked at major type of operations or interventions which refer mainly to large total joint replacements, for example, of the hips or knees, and intermediate interventions which are the more RA-related interventions, so synovectomies, joint fusions. And we showed that on moving from earlier, especially in the case of intermediate interventions, on moving from earlier to more recent treatment periods, the rate of orthopedic surgery declined. And this was in parallel with an improvement in the treatments that we use and our approach to treatment. And part of this treatment revolution and the changes in the approach to treatment was signaled by the arrival of the biologics. The biologics era redefined both the ceiling and the speed of response in RA, a true immunological revolution. And what followed after then was a therapeutic armamentarium of more options, more biologic targets, more intracellular mechanisms, a wealth of options that changed the face of RA from a disease with limited drug options to a disease with an increasingly more personalized treatment armamentarium. And alongside, we saw also more emphasis on non-pharmacological interventions, self-management. We've also written guidelines on that as an important adjunct to the medical therapy for our patients. And alongside came also the biosimilars. And the value of biosimilars was not in giving new efficacy, it was in giving broader opportunity. They enabled more patients to catch that train to the goal of remission. And alongside better treatments came an approach in the way we use the treatments, a change in the treatment strategies. The treat-to-target era, with predefined targets, regular disease activity assessments, and early adaptation of treatment in the case of target not being reached. And part of my own interest in RA, and especially refractory RA, comes from the realization that moderate disease activity in RA was perceived an acceptable state to be in, which was not really the case. Coming back to the ERAS and IRAN cohorts, spanning that period of 26 years, we saw a great opportunity to study how early disease activity states could predict long-term outcome using, again, orthopedic surgery as a surrogate marker of end-stage joint destruction. We studied disease activity states in the first 5 years of disease in high, the red line, moderate in 2 levels, moderate high and moderate low, the blue lines, low and remission, the green lines. And we found that the patients with moderate disease activity did almost as bad as those with high disease activity. And there were significant differences between those in moderate disease activity compared to those in remission. And this study made the point that moderate disease activity is certainly not a benign state to be in, and it also supported the EULAR treat to target thresholds. I have a new friend on stage, it appears, who wants to learn about refractory disease. We will try and ignore it for now. So it also made the informed policy in the UK. So this was a sort of study that made the case to the National Institute for Care and Excellence that these patients with moderate disease activity needed to have access to advanced therapies in the same way that patients with high disease activity had access to these drugs. And we then continue to see an evolution in insights, the importance of treating early, therapy advancements, using combination treatments in clever ways based on the learning over the years in the management of RA, the importance of using certain therapies as bridging therapies like steroids, early treatment escalation. And all of this is reflected in the current EULAR update, the 2025 EULAR update on the management recommendations for RA, led by Josef Smollen and Robert Landauer, which is laid across 3 phases, which I'm going to walk you through it very quickly. And phase 1 starts with something that may sound redundant, having a clinical diagnosis of rheumatoid arthritis. We make this very point also in other guidelines, such as the AxSpA management recommendations, where we want to emphasize that diagnosis should be based on clinical criteria and not on classification criteria, which are used more for research. And then we see the anchor drug in rheumatoid arthritis coming in treatment with methotrexate, combined with short-term glucocorticoids that should be reduced and stopped as rapidly as possible. Another important shift in the treatment paradigm of RA in how we use the steroids and in learning to use them as a bridge and not as a long-term therapy. And we see it also that in the case of intolerance or contraindication to methotrexate, then we have the option of leflunomide or sulfasalazine. Then we are prompted to assess disease activity at 3 months and look at whether target has been achieved at the 6-month time point. If not, then we move into phase 2, where we are asked to introduce a biological DMARD or a targeted synthetic DMARD, a JAK inhibitor, after appropriate risk assessment, as informed by the oral surveillance and other studies. And the JAK inhibitors were certainly part of this new revolution. They essentially moved targeted therapy from the needle form to the tablet form, targeting new intracellular mechanisms of action. But we also came to realize that more options don't necessarily mean easier decisions. This is a study from Stephen Zhao and Kimi Highridge from Manchester in the UK, where they looked at the British Society of Rheumatology Biologics Registry, and they showed that sequential biological or targeted synthetic DMARD therapy in RA, yes, provided options to patients, as we can see here, but it also highlighted complexity and difficult to treat disease. What this study showed is that DAS28 remission or low disease activity became less likely after repeat switching. And in fact, drug survival also shortened across later treatment lines. The challenge in the modern management of RA is not about not having enough drug options. It's about understanding why some patients continue to cycle or switch between treatments without achieving desired outcomes. This is a modern challenge. We then enter phase 3. We are in phase 3 where we are prompted to move on to another advanced therapy if a first one has failed. And in entering any phase 3, in any treatment guideline, and again I refer to the AXPA guidelines where we make this very clear, we are called to stop and think and question, why is our patient not responding to an advanced therapy? What are the reasons? Are we dealing with active disease? Could there be other factors like comorbidities which could mimic active disease and prevent the achievement of target? And luckily we live in an era where we have biomarkers. Biomarkers allow us to match the right patient to the right treatment at the right time. And it's not, the focus shouldn't be about perhaps discovering more, I mean, that will be focus, but it's really important to us to understand how to best use what we have. And also to appreciate that more tools do not automatically mean better outcomes. If we take the example of imaging tools and asking the question of whether imaging can improve remission outcomes, then we've got answers already from well-designed studies that tell us that actually clinical treat to target is sufficient. And it reminds us that the clinical judgment should remain core to the management of our patients. Of course, it doesn't undermine the importance of imaging. We've heard from Anna Maria about imaging and where this can take us. And it's important, as you will see in the latest slides. But it's about keeping clinical judgment as core in the management decisions that we make. So a huge therapeutic revolution, multiple treatment avenues, treat-to-target strategies, it really should work. And it largely does, but not for everyone. And this is where difficult to treat comes into the picture. With Prof. Georg Nagy, under his leadership, we have defined difficult to treat RA. I will not repeat, it's up on the screen. We should be all familiar with it now. It's been out for 5 years, the definition. But what I want to say is that the difficult to treat concept reminds us that, or even challenges us to think that ongoing inflammation doesn't necessarily, ongoing symptoms doesn't necessarily mean ongoing inflammation. And we really have to stop and think. In fact, in work that informed the group's work and the definition and subsequently the management guidelines that we wrote, 3 subgroups were identified as fulfilling this definition of difficult to treat RA. Those non-adherent dissatisfied patients, patients with pain syndromes and obesity, and those patients who were closest to the concept of true refractory RA. And I bring you this study from colleagues in China. It was published earlier this year. It focuses on difficult to treat RA. It's a meta-analysis, 21 studies across continents, 23,000 patients with RA. And this study showed significant associations between lifestyle factors such as smoking, but also obesity, fibromyalgia, and depression, and difficult to treat RA. And these associations were consistent across geographical regions. In fact, it was interesting to see that fibromyalgia had the strongest association with difficult to treat RA. And again, we are reminded with studies like this that not all active disease means inflammation. And when we wrote the EULAR points to consider for the management of difficult to treat RA, in the management algorithm, we remind clinicians to stop at different points and ask questions. Have we got a definition of difficult to treat RA? Have we got the right diagnosis in the first place? What I mentioned earlier also in the RA guidelines. Think about comorbidities that could mimic arthritis signs and symptoms and that could interfere with arthritis assessment. Take, for example, the case of the patient with fibromyalgia or any other pain syndrome. Assessing for tender joint counts can lead to inappropriate decisions in terms of the disease activity state. It can actually lead to either raised or even a lower disease activity score. Take the case of obesity. Assessing for swollen joints in the presence of high BMI is particularly challenging, and it can lead again to either way inappropriately elevated or lower disease activity scores, which then lead to inappropriate treatment decisions. In the algorithm, we are also prompted to think of using imaging, like ultrasound, in the case of doubt when we want to make sure whether there is or there isn't presence of subclinical disease. And if there isn't evidence of robust inflammation, robust signs of inflammation, then we are asked to increase focus on non-pharmacological interventions, self-management, patient education, exercise as important adjuncts to medical therapy. So I think what the difficult to treat array concept did, and we are seeing it increasingly in other disease areas, we've also described it in AxSpA, we're seeing it in psoriatic arthritis, it's come out, we see it in lupus. I think it forces almost a pause on that traditional escalation model in the care of RA. It forces us to stop, question the lack of response to treatment in order to make more appropriate treatment decisions, and importantly, to stop people from inappropriately cycling or switching through multiple treatments and not reaching target. And comorbidities have been mentioned a lot in the context of difficult to treat disease. And we looked a lot at comorbidities also in UK cohorts. And we found that comorbidity burden was high even on first disease presentation, with 1 in 3 people having at least one other coexisting condition together with an RA on presentation. And we saw this increase over time, partly because we have also become better at identifying and screening for comorbidities. We saw a decrease in extra-articular manifestations, probably a reflection of the better treatments. But something that really caught our attention in terms of the comorbidities that were on the rise was obesity. We saw that patients with RA were presenting increasingly with higher body mass index, with more obesity. And this is important. We know that obesity is a big issue, not just in rheumatoid arthritis, but also in other rheumatic diseases. And we also know there's a wealth of evidence that shows that the higher the body mass index, the worse the disease activity and the worse the patient outcomes. And obesity is not just a coexisting condition in RA. It's an active modifier of the disease. It influences inflammation levels, treatment responses, disease outcomes. Here's a Northstar trial in almost 800 untreated early RA patients, randomized to 1 of 4 treatment arms, active conventional treatment, certolizumab, abatacept, or tocilizumab. The primary endpoint here was response to treatment as measured by different measures of disease activity, CDAI, ESSDAI, and DAS28, stratified by body mass index, with those with a BMI of 30 or above shown in yellow lines, and those with a BMI of less than 30 shown in blue. And you can see better here that the proportion of remission was lower in obese individuals, irrespective of treatment used. And this raises naturally the question of whether drugs that target the cardiometabolic axis, such as the GLP-1 receptor agonists, might also help with inflammatory states in RA. We've heard about this also in this Congress. There's been a lot of interest on GLP-1 receptor agonists, and there's more studies now that are coming along that show us that actually GLP-1 receptor agonists seem to lead to improved RA disease outcomes, including also cardiovascular risk profile, which is important, especially when it comes to thinking more holistically about our patients and thinking beyond just the rheumatoid, thinking about comorbidity, risk factors for cardiovascular disease, one of the commonest comorbidities in RA. And it's also been long known, this is work by Helga Ratner in Austria. It's a long time back, but it shows so nicely how every additional comorbidity in RA has been linked with a reduction in the chances of remission or low disease activity after 1 year by around 30% and 20% respectively. Caleb Michaud and Frederick Wolf from the US showed a strong, almost linear association between increasing comorbidity burden and reduced quality of life in patients with RA. Cynthia Crossan and Elena Miyasedova from the Mayo Clinic have shown that depending on the patient's comorbidity patterns, this impacts survival. And we really have to move away from this one-size-fits-all approach when managing our patients with RA. In this study of 1,600 patients with prevalent RA, population-based study with machine learning and latent class analysis, different comorbidity profiles were looked at in different clusters of patients, with C4, the purple line on the graph, having the highest comorbidity burden, and adverse factors such as older age, less DMARD use. And you can see that this had a significant impact on survival compared to those with lower comorbidity burden. And it's not just about physical comorbidity. This Congress has also been very much about mental health disease. We know that comorbidity with depression and anxiety are a big problem in people with RA. Actually, it's a big problem in people across the spectrum of RMDs, and they incrementally worsen health. We have to think about mental health comorbidity. And the once perceived notion that anxiety and depression are a consequence of the long-term pain and disability in RA is changing. Our knowledge is evolving. We're understanding now that there's an important brain-immune connection there. We heard earlier this week from Professor Len Calabrese about immunoception. The connections there are strong. We know that RA is associated with extensive alterations in immunometabolic markers and widespread white matter structural abnormalities. We know that patients with RA have high inflammatory activity, and they're more susceptible to cognitive impairment. We also know that patients with anxiety and depression alongside RA have significantly a lower uptake of self-management behaviors, which we know has an adverse impact on disease outcomes. But we shouldn't just think of comorbidity as a barrier to treatment success. We should change this around completely. We should see it as an opportunity to make more personalized decisions in our management of our patients. And this is what we see from this work by Peter Taylor. In patients who have already been through one TNF inhibitor, we are prompted to think about patient and disease factors and presence of comorbidity that can help us make more personalized treatment decisions. Take, for example, the case of interstitial lung disease or demyelination. We know that B-cell depletion is a strongly favored approach over TNF inhibition. We have come a long way in understanding how comorbidities can influence disease outcomes and how we should think about them and how we should manage them in the context of RA. And comorbidities are certainly an important part of the puzzle, but they do not explain the whole picture. We still know that even in patients without a significant comorbidity burden, some of them will not achieve those desired treatment outcomes. And this is where we're encouraged to think about RA from a broader lens and not just about suppressing inflammation. Mina Lilly-Day, a PhD fellow at King's, looked at the literature, the existing literature in RA and factors associated with different adverse outcomes in RA. And there's a number of different factors that have been described in the literature: lifestyle, disease-related, patient-related, socioeconomic factors. The problem with studies that have shown this is that they largely study these parameters in isolation or a few at a time, and there's no comprehensive one framework to study these parameters under the same framework so that we can also understand how these factors might interrelate, how they might drive each other, adding to adverse disease outcomes and disease burden. And this is where new concepts in the way we think about RA come into the picture. The concept of syndemics. It's not a new concept as such, and some of you will have heard me talk about this at the beginning of the week. If we have any ACI EULAR exchange fellows in the audience, you will have heard me talk about this, the syndemics theory, the syndemics framework. It's been around for years, but more in the context of diseases outside rheumatology, and it started in the world of HIV. But what the syndemics framework encourages us to do is to think about both biological and non-biological drivers of adverse outcomes in disease, to think about them together, to think beyond just biology, and to think about the social context that interacts with biology to drive disease. And this is another important shift in the treatment paradigm of RA, a shift away from purely a biomedical model of disease to a more biopsychosocial model of disease, a multimodal model of care. This is where we should be heading, and this is what our patients want us to do. So back here at King's College London, and with the support of Foreum, we sought to understand the psychosocial determinants of essentially refractory disease in RA. And we learned a lot from this exercise. This was a mixed methods project with a qualitative phase, which is the one you see here at the front. And we got to learn directly from patients through qualitative work that there are important psychosocial determinants that influence outcomes in RA. Health literacy was an interesting one. We then went on to study this in greater detail. But another learning that became apparent, other than the importance of psychosocial determinants that influence outcomes in RA, was the fact that the tools that we currently have do not adequately capture lived disease burden in RA patients. And pain is an important parameter when it comes to lived disease burden. It's a big issue. But again, we have come a long way in our understanding of disease and pain mechanisms. We now understand that pain is not just a consequence of inflammation and disability in RA. There's more to this. There's more factors. We understand different pain mechanisms, nociceptive, neuropathic, nociplastic pain. And we also understand that there's different risk factors behind these different types of pain. We also know that in different phases of life, there are different triggers for pain. If you take, for example, adulthood, we see that poor socioeconomic position, obesity, sleep disturbance, depression and anxiety, trauma and stressors, physical injuries are all risk factors for nociplastic pain. But the answer here is not escalation of immunosuppression. And this is where it all becomes relevant when we are treating our patients with RA. Fatigue is another big issue. Largely underreported and under-recognized, but a big problem for our patients. Very silent as well. And I bring this study because it's a study in difficult to treat RA that looked at associations between fatigue and found fatigue to be strongly associated, first of all, with difficult to treat disease, to be associated with emotional, cognitive coping mechanisms, as one might expect. But these were associations that were more strongly prominent in women. And again, through work of this sort, we are reminded that it's important to evaluate symptoms like fatigue in a multidimensional perspective, considering also gender-specific differences. So I think one of the most important paradigm shifts of all in the story of RA has been the shift away from thinking about RA very much as an index disease right at the center of care, to a more patient-centric approach where the patient moves right to the center with rheumatoid arthritis and any other comorbidities around the patient, social context, and any other factors that could be influencing treatment and disease outcomes, all being given attention as part of a more holistic and comprehensive approach to care. We have shifted away from thinking around comorbidity, which really reminds us of there being an index disease, to more multimorbidity terms, where it's more encompassing and it has a more patient-centric approach to it. If there is any patients in the audience, they will relate very much to this. People want to be heard. They want to be given proper information, balanced information with compassionate integrity. They need to be part of that shared decision-making. I've been hearing about this all along this EULAR Congress and in every meeting I have with patients. They want to feel trust. They want to feel confidence in our hands. And they want continuity and integration of care. They do not want their care to be fragmented. They do not want us, as rheumatologists, to be thinking about the rheumatoid arthritis and nothing else. They want us to think about the whole picture. This is, to my opinion, the real paradigm shift, the focus on the whole patient and more intelligently treating our patients. So I think if I was to break this down into the two major paradigm shifts here in the story of RA, we've got the initial paradigm shift, which is all about inflammation control, treat to target, the biologic revolution, making remission possible, to the current paradigm shift, recognizing heterogeneity, that every person is different. More therapeutic targets, thinking about multimorbidity, patient priorities, symptoms that matter to patients and that can influence disease assessment, and it can also lead to discordance between patients and physicians. Multimodal care and new frameworks of thinking, which encourage us to think very much around bringing both biological and non-biological drivers of disease into the picture to more holistically manage our patients. And we are reminded throughout this paradigm shift that precision medicine should not only be about molecular precision, but precision in understanding the patient. Very much like climbing Mount Everest, we should remember that the journey to remission in RA is not a linear one. There are multiple obstacles, but we are in a position that we understand these obstacles now. We understand difficult to treat RA more. We understand that non-inflammatory pain exists, comorbidities. We understand the issues with delayed escalation, but we also have the tools at each step of the journey to stop and apply these tools to make appropriate decisions. It requires strategy, adaptation, and persistence, but above all, a good understanding of the person with the disease. We go back to what Hippocrates said. There's a Greek in me now coming out. What Hippocrates said hundreds of years back, it's more important to understand what sort of person has the disease, and more important to understand that rather than what disease a person has. So what might we expect next? Well, again, as part of this Congress and previous Congresses, we've heard a lot about preventing disease before disease even begins. And studies, including the Treat Earlier trial, have shown that in the right patients, in high-risk patients with clinical arthralgia, positive serology, if we intervene early with treatment, we can delay the onset of disease. The APIPRA trial and the ARIA trial have shown us that if we intervene with biologics, abatacept in this case, then again we can delay the onset of disease in high-risk individuals. Essentially, we go back to what historical studies have also showed us, that actually if we treat early, the outcomes of our patients will be better. But I've got another thought as well that I thought would resonate very much with Diane and some of you here as well. Perhaps the next target in RA is not just cytokine, it's a whole ecosystem. We have known about this mosaic of autoimmunity, the interaction between our genes, our immune system, our hormones, and the environment, external factors. And again, we've heard about this throughout this conference. Diet, gut dysbiosis are implicated in driving disease, and perhaps this is where the next target would be. We're seeing an increase in the literature of nutrition and rheumatic diseases and the impact on outcomes, Mediterranean diet, anti-inflammatory diets, and how this can lead to improved patient outcomes and disease activity states. Perhaps the next target is this, microbiome-targeted therapies, still experimental, but maybe part of the next chapter. So, we have come to the end of an extraordinary journey where we have learned the importance of treating early, treating to target, escalating promptly, thinking of difficult to treat RA, questioning treatment failure, distinguishing between inflammatory and non-inflammatory failure. I appreciate a hard task, but we are thinking about this and thinking beyond simply more drugs. So I think we have to remain optimistic. Some of you will recognize Pierre-Auguste Renoir. His art has marked history, precision, beauty. But unfortunately, Renoir suffered with debilitating rheumatoid arthritis. And this affected his style. His brushwork, as you can see, his brushwork broadened. He had to adapt to the limitations imposed by his disease. But our patients in this current era shouldn't have to. Because if we go back to where we began and where we started with this journey, we have fundamentally changed the natural history of RA. We have changed what is possible. The challenge is to ensure that every person living with a disease truly benefits from this progress. I will stop there. There's a lot of people to thank, lots of funders for all this work, but above all, the patients who have been the biggest driver of this journey and this paradigm shift, and who will remain the biggest inspiration for what comes next. Thank you for listening.
Elena, thank you very much for this very nice and comprehensive lecture and maybe a bit of future in RA. The talk is now open to questions. I have here 2 questions from the audience. What is your opinion on the use of combination therapy with BD-MARDs? Should this approach be considered for inclusion in the future EULAR recommendations?
So I'm aware that there was a lot of discussion around combination treatment, also in the 2022, but also in the current 2025 EULAR update for the management of RA. And the reason I believe that led to the decision and the way the algorithm is currently defined in the current update is because non-inferiority was not shown with methotrexate alone together with steroids. And the thinking there, I believe, is that methotrexate is an important drug. It works together with steroids, and if we can get our patients quickly through this first stage, and we can get onto options that we now have more broadly with biosimilars, which have lowered costs as well in terms of access to these advanced therapies, then we know that they perform the same. And we have less side effects also with less combination treatments. And I think this is the reason why that approach was taken.
Yeah. Thank you very much. We have another question. Please introduce yourself and quick question, please.
Yeah. My name is Hannah Kazkaz. I'm a rheumatology consultant at University College Hospital. Excellent talk. I'm really impressed by the shifts and talking about a person rather than disease. And the reason I'm asking is I see people with hypermobility. So people with the flexibility of the joint, 20% of the population are, they have this, it's a body type. The problem is that the people with hypermobility can present as arthralgia rather than fibromyalgia. And in reality, a number of them will be labeled as having arthritis for a long period of time, even started on biologic, till someone said, well, let's see what happens and why they're not responding. And I wonder in your, the EULAR guidelines, I have to say I need to look it up. You said about painful syndrome. Did you specifically look at or highlight hypermobility there and encourage people to look for it as a reason for not responding to treatment?
So I think I should say that I wasn't part of the EULAR RA recommendations. I was part of the AXPA recommendations. But what we are encouraged to do is I don't think there was, if I'm not mistaken, specific reference to hypermobility, but we are encouraged to think about all potential other causes that can lead to inappropriate and inaccurate assessment of disease activity that then leads to inappropriate decision. I think this is a real life problem. Yeah. I see it a lot in my clinics as well, and this is where modalities like ultrasound, biomarkers, where we have to use the tools that we have to make a more robust assessment in a way that will guide our treatment more appropriately. It's a big issue. It's real life.
Specifically with mechanical, so if it's for sacroiliitis sometimes, the atypical sacroiliitis, it could be actually purely mechanical because someone is hypermobile. So it's very good. I think I'm very impressed, and thank you very much for highlighting that.
Thank you.
Yes, I think we have to close the session because the next one is pushing. But thank you for listening, and thank you very much for this excellent holistic talk. I think you have more questions, but you can...
I will stay here. So you can come and find me at the front. Thank you.
Thank you very much.
But